Good afternoon. I make this title, Suspicion Makes a Physician Perfect, because without suspicion, pulmonary embolism diagnosis might be missed. So let us see our first case. Mrs. A's 21-year-old lady presented in CCU with chest pain, breathlessness, and cough for 3 days. This is her emergency ECG. Now look at this ECG. There is a T inversion in V1 to V6 and as well as 3 and AVF. So by seeing this ECG, anyone can assume that this might be case of acute coronary syndrome. But if we look carefully, there is a S wave in lead 1 and there is also Q wave in lead 3 and T inversion in lead 3. So S on Q3 T3 pattern. On examination, general examination, we could see that there is a unilateral leg swelling. So this patient having unilateral leg swelling presented with breathlessness, so one might have suspicion of a pulmonary embolism. So patient has normotensive, tachycardic, tachypneic, orthopneic, and unremarkable precordial findings, as well as lung bases are clear and oxygen saturation is low. So we did the bedside echocardiography that reveals the right ventricle is dilated, left ventricle is D-shaped, and also there is a RV dysfunction measured by TAPC. Look at this video clip. RA-RV is dilated, and look at base and mid level of the RV is akinetic, whereas apex is contractile. So this is called McConnell signs. There is also 60-60 signs. That means pulmonary valve acceleration time less than 60 seconds, as well as there is a TR gradient, TR peak gradient is less than 60 millimeter mercury. So chest X-ray was unremarkable. For confirmation, we did the CT pulmonary angiogram. Look at here. CT pulmonary angiogram reveals there is a thrombus in the right and left pulmonary artery. Thrombus in the right and left pulmonary artery. So we also did the antiphospholipid antibody that was raised, a D-dimer was raised, and anti-proBNP is also raised. So diagnosis of antiphospholipid antibody syndrome, deep venous thrombosis left, and acute pulmonary thromboembolism. We treated the patient with oxygen, subcutaneous enoxaparin, and patient was discharged when she felt well, and after discharge lifelong orphan as the patient was diagnosed with antiphospholipid antibody syndrome. So there are a predisposing factor. We must have to remember that without this predisposing factor, we may, if we do not query for this predisposing factor, we may miss the diagnosis. There may be fracture lower limb, there is a hip or knee replacement, there may be pregnancy, peripartum period, contraceptive use, and cancer patients. So we have to mind these risk factors. These are the hemodynamic cycle in acute pulmonary embolism. What happened when acute pulmonary embolism happened? There is an increased RV afterload that leads to RV output, decreased RV output, and ultimately LV preload decrease, cardiac output decrease, and ultimately RV oxygen delivery decrease. If untreated, the patient may progress to obstetric shock and death. My second case is on a fine admission morning, I received a phone call from CCU and rushed to the CCU. A 42-year-old gentleman presented with chest pain for 3 days and shortness of breath for 3 days. He had a syncopal attack for 10 days back. Patient was in shock, and his SpO2 was 83%. And again, the precordial findings is normal and lung bases are clear. So look at this ECG. This ECG also reveals there is a S on Q3 T3 pattern along with the T inversion in anterior leads. So we did the bedside echocardiography that reveals RA-RV dilated and there is a RV dysfunction, but LV function is normal. She had a history of left lower limb swelling and he admitted different hospital but no document. So with this background, history of left lower limb swelling and patient breathlessness, lung bases clear, oxygen saturation normal, RA-RV dilated, we can make a diagnosis of acute pulmonary embolism. As the patient was in shock, so he categorized a very high risk, so we thrombolized the patient. After thrombolysis, the greatest benefit of thrombolysis is observed if treatment is initiated within 48 hours of symptom of onset. It can be useful in patients who have had symptoms 6 to 14 days. So this is a bedside echograph, bedside chest X-ray, though the quality is not good, but we can assume that there is a both lower lung field is hazy. So for confirmation, we can able to manage a CT angiogram for this patient. You look at here, there is a left pulmonary artery is totally occluded. So this is the CT angiogram report. So patient was on enoxaparin, but patient was still dyspneic. He couldn't maintain oxygen saturation without 10 to 15 liter of oxygen. So what could do for this patient? Should we send for surgical embolectomy, or should we send him to a cath lab, or continue medical management? Ongoing medical management, patient was still dyspneic, not improving. So we decided to send the patient to cath lab with a view if we can make a passage through the left pulmonary artery with wire and angioplasty. First, we see the coronary angiogram. The coronary angiogram is normal. So we then do the pulmonary angiography, took a catheter in the pulmonary artery and give the shot. Look at here, left-sided pulmonary totally occluded. No dye is going to the left side. This is another view, total occluded left pulmonary artery. At this point, we just switch our plan that it will be very difficult to pass a wire and pass a balloon and making a passage. So we shift our plan. We send the patient to our surgical colleagues. They are very good friend of us. I must thank Dr. Sanjay Raha as he took the trouble and did the embolectomy. This is the embolus after embolectomy. So this is our patient. He is now under our follow-up. He is doing well with ongoing warfarin therapy. So I want to conclude with few summary. 33% of people with pulmonary embolism die before they get a diagnosis and treatment. Diagnostic strategy of pulmonary embolism is based on clinical probability. We must have suspicion, and so we must know the risk factors. Low oxygen saturation with unremarkable precordial finding and normal lung base give a clue to the diagnosis of acute pulmonary embolism with a predisposing factors. Bedside echo is useful, CT pulmonary angiography is confirmatory. There is a lifelong risk of venous thromboembolism recurrence after a first episode of pulmonary embolism. So, anticoagulation is required lifelong. After acute pulmonary embolism, patients should not be lost to follow-up because there might be chance of recurrence. So, thank you for your patient hearing.